Thank you, Raul, for inviting me to speak at your great course. Sorry I could not be there, or I could not give this live as I'm traveling this week. The topic assigned to me is to discuss liver injury due to new agents such as monoclonal antibodies and RNA therapeutics. What are the challenges in understanding and detection? I just want to start with overview. Newer therapeutic approaches such as cancer and non-cancer biologics, including immune checkpoint inhibitors, RNA therapeutics, and gene therapies are very rapidly evolving. However, they are important emerging causes of liver injury. There are many challenges. First of all, there are just a lot of them, and they're growing every year. They're continuously evolving targets, complex delivery systems, and disease states for which these are administered. The patient population is sick, they have multiple comorbidities, and they take a lot of medications. Treatment effect can last months or sometimes forever, making the challenge and the traditional way we adjudicate quite difficult. Finally, the disease presentation is quite heterogeneous. It can be classic liver injury, AIH-like pseudocirrhosis, so on and so forth. Also, it can happen after a single dose or very delayed presentation many months after a therapy has been administered. This is the outline. I will discuss biologics, both non-cancer as well as cancer, RNA therapeutics, and finally a couple slides on gene therapy. What are biologics? This is a excerpt I took from Fernando's great paper published in 2022. Biologics mean agents that target biological pathways that are thought to be critical for a particular disease. They're usually obtained either from or produced by a living organism. Biologics are typically administered subcutaneously, IM, or intravenous. In general, though, when we say biologics, we are talking about monoclonal antibodies. Technically, insulin or vaccines are also considered biologic by broader definition, but for this purpose, these are monoclonal antibodies. By the FDA, there are a number of them. As many as 180 have been approved. 70 are approximately for cancer, and for non-cancer indications, maybe up to 110. However, there is some cross usage. This is the framework I want to walk you through. These are biologics for non-cancer indications. So what I show you here in far left column are the disease states, rheumatologic, dermatologic, for example, psoriasis and eczema, severe asthma, of course, ulcerative colitis, Crohn's disease, multiple sclerosis, and rare things such as Castleman syndrome. And there are a number of diseases in the second column. Targets, though, any particular cytokine or its receptor can be a target for a biologic. There are a number of them that continue to evolve. What I've shown here are targets in red font. They are the ones that have been generally reported to cause DILI, TNF-alpha, interleukin-6, complement 5 alpha receptor, and then alpha-4 integrin. From this slide, there are a lot of targets. Remember TNF-alpha, IL-6, alpha-4 integrin, and complement 5 alpha receptor. Okay, let me just walk you through TNF-alpha. You all know the prototype, the oldest one is infliximab, used for a number of conditions, and adalimumab. And these can cause, these are associated with moderate risk of liver injury. The phenotype is AIH-like, you know this. IL-6 receptor, though, tocilizumab and others, the risk supposedly higher than for TNF-alpha antagonists. These are typical high aminotransferases. You can have acute, severe acute liver injury, even acute liver failure. C5 alpha receptor antagonist avacopan is used for ANCA-negative vasculitis There may be a DILI signature. Interestingly, reports from Japan state that this may be associated with vanishing bile duct syndrome. Finally, alpha-4 integrin is natalizumab. This is used for multiple sclerosis, maybe for ulcerative colitis, is associated with rare but severe cases of DILI. There are reports after a single first dose severe liver injury as well. Also, you must keep in mind CD20 antagonists such as rituximab may be associated with hepatitis B reactivation. A stoplight for non-cancer biologic risk of DILI. Red is higher risk. These are IL-6 inhibitors or natalizumab, which is alpha-4 integrin. The DILI is typical, whereas yellow is anti-TNF, for example, infliximab, immune phenotype, whereas the safer ones are other biologics, for example, IL-17, IL-22, IL-4, and so on and so forth. Just a quick rehash of phenotypic heterogeneity, classic presentation, AIH-like, vanishing bile duct syndrome, and reactivation of hepatitis B, for example, with CD20 receptor antagonists such as rituximab. What are the challenges in their detection and adjudication? Typical latency for this class is 8 to 12 weeks, but severe DILI has been reported after a single infusion of natalizumab. You know, autoantibodies after TNF-alpha antagonists, they can help you with adjudication, but they also can be epiphenomena. Recently, we experienced a case a month after a single dose of long-acting TNF-alpha antagonist. Liver injury happened, but the patient was also taking a herbal, high-dose dietary supplement, and the patient developed a new onset ANA positivity. Is it HDS DILI, where ANA is just an epiphenomena, or is this AIH-like liver injury from TNF-alpha antagonist where ANA is associated with liver injury? These are some of the dilemmas. And D challenge may not readily be associated with rapid improvement. Typical DILI enzymes go up and then rapidly come down with the D challenge, whereas if you have immune-mediated injury, they may just stay high for a length of time. That could be a problem as you're trying to adjudicate. Con meds, for example, non-steroidals, if you're giving monoclonal antibodies for rheumatological conditions, sulfasalazine or high-dose steroids if you're giving biologics for ulcerative colitis. And interestingly, the avacopan, as I said, can be associated, was been reported to be associated with vanishing bile duct syndrome. There was high usage of trimethoprim and sulfamethoxazole. Just walking you through now to cancer biologics. I just sort of categorize them into 4 classes: conventional monoclonal antibodies, for example, like rituximab or trastuzumab. And then there are antibody drug conjugates, where an antibody and a chemotherapeutic agent are put together, and the monoclonal antibody goes to a specific target. These tend to be more hepatotoxic, and the pattern of liver injury is related to the compound that you're attaching to the antibody. And then there are bispecific antibodies. These are generally not hepatotoxic, but they may lead to cytokine release syndrome. Finally, the big kahuna is the immune checkpoint inhibitors. There are four in the market used for a number of cancers and various combinations, and then also varying number of other cancer drugs that they receive. In terms of the pattern of liver injury, for conventional monoclonal antibodies, typically hepatocellular injury, hepatitis B activation is an issue. With trastuzumab, pseudocirrhosis with ascites, splenomegaly, shrunken liver can happen, okay? Whereas antibody drug conjugates, in addition to these, you could also have nodular regenerative hyperplasia, and you can have sinusoidal obstruction syndrome. And then finally, ICIs, immune checkpoint inhibitors. Typical injury is immune mediated, although you don't really have a high autoantibodies, but they respond to steroids. Just the challenges, as I touched on, tremendous heterogeneity. However, though liver injury due to ICIs is a bit consistent, latency is widely variable depending on the compound. Underlying cancer and the concomitant medications are an issue. Interesting phenomena, ICIs may predispose individuals to tyrosine kinase inhibitor DILI. This is more recent, requiring validation, but seems to be a true phenomenon. Okay. Just the last few slides about the RNA therapeutics and gene therapy. This is a framework to help you about RNA therapeutics. When you give about RNA therapeutics, there are 3 types of RNA therapeutics. Small interference RNA or siRNA, this is gene silencing. And then there is antisense oligonucleotide, popularly called ASOs. And this is also gene silencing. Either you're doing siRNA or ASO to silence a particular gene. This is temporary, not lifelong. And then, of course, there are mRNA therapeutics where you're trying to increase the protein production. Okay, these are the RNA therapeutics. However, for them to be delivered, you have vehicle, the delivery mechanism, which is either GalNAc, which is specific to hepatocytes. They target the sialoglycoprotein receptor, which is specific to human hepatocytes. Okay, and then there are the lipid nanoparticles. In other words, either siRNA or ASO or mRNA can be packaged with lipid nanoparticles. The lipid nanoparticles aren't necessarily higher risk for DILI, but just depends on what type of LPN and the cargo it carries. Okay, current standard is more GalNAc and more siRNA. You don't see as much ASO and lipid nanoparticles. You may see, but they are not as common. Okay. And just to continuing on the talking points, the GalNAc platform, this is targets hepatocytes because it is to a sialoglycoprotein receptor that is specific to hepatocytes. If there is a liver injury, it tends to be sort of a classic DILI type. Whereas the LNP lipid nanoparticle platforms distribute biology across immune and liver interface. Therefore, you may see immune type liver injury. This distinction explains the DILI phenotype differences in these delivery platforms. Okay, big inflection point for safety is when the field moved from non-targeted ASOs to GalNAc conjugated ASOs or siRNA. This has been a big leap in improving the safety of RNA therapeutics. Finally, though, the NLPs by themselves are not categorically more hepatotoxic, but they're immunologically more active. They are across hepatocytes and the immune cells, so less specific and maybe more immune-mediated liver injury. Okay. Then how about liver injury from gene therapy? The key talking points are in gene therapy, you are going after a particular location of a gene in DNA, unlike RNA where the target is an RNA, mRNA in a transcription translation system. Okay, when you're doing gene therapy, the liver is the default exposure organ, although there are gene therapy to adipocytes and so forth. And the dominant mechanism is immune mediated, not classic DILI. These are either generally related to the platform or the vehicle that is taking the gene therapy. So either this is adeno-associated virus or lipid nanoparticle or in vivo gene editing, okay? And the phenotypes are generally AST and ALT increases with AAV, but you can have a immune type presentation weeks and months after AAV gene therapy, and these tend to be steroid responsive. Dose of the vehicle is the key determinant here. If you have a high vector dose, you're going to have a high hepatocyte transduction and higher immune activation. What you have seen across AAV programs is clear dose toxicity relationship. You know, NLP-based editing therapies are also seem to show some liver toxicity. I'll give you one illustration. So bottom line is delivery platform plus cargo load plus host biology what determines the frequency and severity of liver disease. I just want to give you one example of gene therapy liver toxicity from a compound from Intellia Therapeutics. This is ultra-modern gene therapy approach where patients with transthyretin amyloidosis are given this compound, which is gene therapy, where they have CRISPR gene editing of the TTR, transthyretin location in the DNA, where the CRISPR machinery, so the mRNA that expresses Cas9 as well as the guiding RNA, they're packaged into lipid nanoparticle and administered, okay? There was one case of severe liver toxicity with very high aminotransferases and jaundice, and this patient was hospitalized. This led to FDA placing this program on clinical hold temporarily. My understanding is this is back to enrolling and studying patients. So the TTR as a target has been previously successfully employed by siRNA and ASO approaches. So therefore it is not the target itself. So current thinking is the vehicle LNP. However, LNP is used for other approaches without liver toxicity. However, though LNP used for this particular program seems to be tweaked, it's a proprietary approach where ionized lipid formulation to target ApoE and LDL receptor to be more specific uptake. That may be what happened. Nonetheless, this is in vivo gene editing with LNP packaging that led to a severe case of DILI. Just to tell you how the amount of complexity that we are dealing with here. Just to wrap up my talk once again, to summarize, the numerous therapeutic approaches are growing quite rapidly, and however, though these are important causes of liver injury, there are many challenges. There are just a lot of them. They're growing every year. They're continuously evolving targets, complex delivery systems, and disease states make it very difficult for us to get a handle on. Patients are sick. There are a number of medications, and the latency can be very long. So is the D challenge. You know, sometimes the treatment effect may last weeks and months or even indefinite. Finally, heterogeneity of presentation, classic liver injury, AIH-like. You know, we talked about pseudocirrhosis, NRH. This makes the whole space quite complicated. So I would say the newer agents are rapidly evolving, and it is something we need to continue to educate ourselves on the lookout for new variants that pop up. Okay, with that, I'm going to conclude my talk, and I appreciate your attention.